one other person who was interested in family medicine at my medical school. So it was a pretty hostile environment there. And so I'm already excited that there's so many people who seem to be interested in family medicine, stick together and support each other. So I was interested in I'm interested in maternal child health. So I was really thinking about OB versus family medicine, and really struggled with that for most of my medical school career until I did a rotation on the Navajo reservation, and I was working with some of the OBGYNs, and I realized that I actually don't love surgery. Is that the whole time that I was in, these long surgeries for GYN stuff, I just kept thinking, so the kitchen, you got free breakfast from like a certain amount of time. And I kept thinking, oh my God, I'm going to be in the surgery and miss breakfast. And I realized that I don't love surgery. And so that really helped me realize that I didn't need to do OBGYN, because as a family doctor, I can deliver babies, I can take care of the pregnant women, I can do the deliveries, take care of their babies, and then end up, through word of mouth, end up taking care of the whole family. So that was one major reason that I chose family medicine. And then I also realized that I love working with my hands. But again, it doesn't have to be a surgery. It's that there's so many procedures that I do in my regular practice. I do birth control procedures like IUDs and Nexplanons. I do steroid injections for joints. I do paracentesis to take fluid out of the belly. I do intubations now, which we'll talk about in a second. So I do kind of like a whole gamut of different procedures that are small procedures, but you still get to do hands-on. So those were kind of some major reasons that I chose family medicine. And then I ended up doing my rotation in family medicine, my clerkship actually in Montefiore, and I realized I just really liked the people, the doctors. And so that was a huge thing, is, trying to figure out which specialty for me. Oh, I jive with these people. I could totally be friends with them too. Um, so I graduated from residency in 2014, and I had always wanted to work on a Native American reservation. I grew up when I was a little kid on the Navajo reservation, and I just really wanted to do kind of what, the full spectrum family medicine that is not very common, these days. And so I found out about Zuni, New Mexico, which is where I live and I work. And I just want to make a plug. We totally enjoy having medical students come and rotate with us. My experience, if you guys come, because I used to be in charge of the program, is that you'll get tons of procedural experience, tons of clinical experience. And someone can give my email later if anyone's interested in rotating with us, because we love having students. And so I work at this really small really small hospital. It's run entirely by primary care doctors, so family medicine and med peds. There's no specialists at all, which is both really fun and also really scary. And one of the things with medicine, as you'll notice, is I'm sure as first and second years, you're probably learning so many things for the first time, but I've been out in practice for 6.5 years, and I'm still learning so many new things. And I'm going to be, learning new things for the rest of my life, which is really humbling and also really exciting and makes it fun. So as part of my practice, because I want to do full spectrum, I do inpatient medicine a little bit. Now, we don't have surgeries here, and we don't have an ICU. So the closest place to transfer someone is 45 minutes away for something like, a typical, like an appendectomy or something that's not that challenging. If it's something that needs specialist care or a trauma, or maybe someone who's preterm and is going into preterm labor, then you actually have to fly them to Albuquerque, which is a 2.5-hour drive usually. And Samantha, how long did you want me to talk for, just so I don't talk too much?
I think we're doing good on time for right now. We're going to open up the conversation to COVID in general at the end, so each panelist can talk about their own situation, and we were hoping to have that as more of a discussion between the people. So after you finish talking about family medicine in general, we'll move on to the next panelist.
Perfect. Sounds good. So I do a mixture of inpatient, ER, urgent care, OB, and again, we don't have C-section capabilities. So you have to be really careful about who can deliver here. And we've definitely had some scary situations where we've had to transfer people in the ambulance, to the closest hospital 45 minutes away. I do outpatient care, prenatal care, kind of a mixture of all of it. And just briefly, COVID is really bad. You might have seen New York Times articles about Navajo Nation, which is the nation next to us. 40% of my patients are Navajo. And then Zuni are 60% of my patients, very traditional, religious Native American tribe. And we are having our big surge right now. And it's pretty scary because it's this challenge. I'm an outsider, even though I've been here for 6 years, and their most important religious activities are happening this weekend. And so it's been a challenge trying to give information about how to stay safe with COVID. Now, ideally, I would tell everyone, don't do anything, please stay home. But at the same time, the most religious people in the community feel that if they do not celebrate Shalako, which is the name of the religious event, that could have detrimental effects for the entire world. So it's this really interesting challenge of Western medicine and then tradition religion trying to come up to a compromise about how to stay safe, but also, not be paternalistic. And honestly, even if we were paternalistic, people would not listen to us. So trying to figure out a balance. So that's a little bit about Zuni right now.
That was a great opening. Thank you so much for sharing a little bit about your experiences. Does someone want to introduce the next panelist? Or tell the next panelist who's speaking?
Okay, we can hear from Dr. Rachel Ema now.
Awesome. Hi, my name is Rachel Ema. I am a family physician. I'm class of '01 from Sophie. I did my last 2 years of medical school at Stony Brook, and I graduated in 2003 from there. And then from there, I came to Florida in Daytona Beach. They have an unopposed family medicine, or had an unopposed family medicine program, meaning that family medicine residency was the only residency in the hospital. And I was looking for that because kind of at the time when I was doing family medicine, I was the only one from my medical school that went into family medicine residency. So I knew I kind of wanted an environment where the learning would be great and I wouldn't have to fight other specialties in terms of trying to get cases and things like that. And then once I moved to Florida, I decided I loved it. So I stayed and I have been here since. I work primarily solely outpatient family medicine with physician associates. It's a multi-specialty group. So we have everything from pediatrics to OBGYN to surgery, and we're affiliated with one of the main hospitals here in Orlando, Orlando Health. And I see everything. The great thing with the company is that we have the opportunity to do as much or as little as we want. So I chose to see from kids the age of 5 all the way up to adults till death. I do a little bit of GYN. So I do like pap smears and pelvic exams, things like that. I do some procedures, not a lot. Procedures was never my thing for family medicine. And that's one of the things I kind of, when talking about what interested me in family medicine, I actually thought when I was in Sophie Davis and actually the first or the third year of medical school, I thought for sure pediatrics was what I was going to do. And it wasn't until I started my clinical rotations that I realized I kind of like everything. I love medicine. I love OB and GYN. And then of course I love pediatrics. So when my 4th year came and I had to do a sub-I, I couldn't decide. So I was debating between med peds and family practice. And I did a sub-I in both medicine and in family medicine. And I just realized that family medicine, I loved it because it's just all encompassing. You can do as much or as little as you want. I mean, the wealth of knowledge that's there. I have several colleagues who have done emergency medicine, some colleagues who practice OB, so I mean, you can just do anything. The sky's the limit as long as you're willing to learn. So much so, I take a particular interest in integrative medicine. I think family medicine is a great jumping off point for that in terms of, I'm a big believer in the connection between the body, mind, and soul and how it affects people's health and well-being. And I'm in the middle, I just started an integrative medicine fellowship through the University of Arizona. So I'm learning that and kind of incorporating that into my practice as well too. In terms of the COVID, when things first started, it was really bad in New York, and I went to school and my medical school and everything in New York. So I still have friends and colleagues who work there. So when things were getting really bad in New York, it was kind of, I felt like I was almost on the front line because I was hearing from them, okay, what to expect and what was going on and how bad it was. But it was very hard because here in Florida, we weren't seeing a lot of that going on. So we were trying to take our precautions and do the things we needed to do, but it was very hard to convince patients to do that. The other thing I think, which is a great disservice, is that unfortunately the whole coronavirus situation is very politicized. So a lot of people, felt as if they had to wear a mask. It was against their freedoms. And so we saw a lot of that here. So it was just trying to kind of educate patients and say, this is what we need to do. I mean, we started to see our surge in the summer, and we kind of expected it because around the time like Memorial Day, people were going to the beaches. I mean, they were crowded. Nobody was social distancing, wearing masks. So we started, our peak was in the summer months. And I think then the tide started to change a little bit. And when people started to realize, okay, I see this is affecting my family members, I see it's out there. So we still have a little bit of resistance from people not wanting to social distance or wear their masks. But I think now people are kind of jumping on board, and we're starting to see another little peak kind of coming up right now. We're anticipating it probably will get a little bit worse because we've been seeing a lot of people, especially with the holidays, Thanksgiving, and a lot of people are traveling and stuff for Christmas. So we expect it to continue to go up, but that's what we're kind of seeing on an outpatient setting. That's it.
Thank you for sharing, Dr. Ima. Dr. Leung, I believe you are next to share.
Okay, well, thank you very much. I think I'm one of the original, I guess. I graduated from Sylvia Davis in 1978. We were the second class. And I guess I have done quite a bit since, or travel a long path since graduation. So I went to NYU and got my MD degree there and graduated in 1980. And you probably know NYU at this point doesn't have a Department of Family Medicine. So I kind of share some of the story that Rachel talked about. I rotate through all my clerkship and say, well, I love pediatric, I love OB, I like everything. One of the surgeons actually even tried to recruit me into go into surgery because I love to do procedure. I want to do things with, a hands-on procedure type thing. Until someone came from Group Health from Seattle came and talked to us in the interest group. And they talked about how they took care of patients and did everything from delivering baby to geriatric, to doing procedures, and really got to know patients in a very deep, meaningful ways, and contributing to really make a big difference in patients' lives. And I say, whoa, that's my calling. So that's when I kind of decided to do family medicine. And I went and did an elective in Long Beach, California, and just literally fell in love with it. So I did my residency in Swedish Hospital in Seattle and just absolutely loved Seattle and stayed on and for about 9 years until my husband got recruited to Penn State, which is in Hershey, Pennsylvania. So then we moved into Pennsylvania. But when I left, I just really loved everything, the practice and my patients. And I have actually delivered a woman's third child, and the first child that I delivered was actually taller than me. So I think family medicine has so much to offer. I just loved it. And I still remember early on in my after graduating and early in my practice, I was still assisting surgery as the first assist for a number of years. And I was doing deliveries, I was putting in IUD and tons of procedures. But then when I got into Penn State, I discovered a new love. I started serving as a clerkship director. I went to a lot of the SFM meeting, which is the Society of Teacher of Family Medicine, and just got really excited about doing research, creating curriculum, and innovating things. And then I discovered what I really like to do is innovation, really innovate things that people haven't done before. So I got heavily into building new curriculum And I don't know how many of you know about the FM cases or the AFCA 4 cases. So these are the computer cases that are designed to teach the Cluster curriculum for family medicine, so the national curriculum for SDFM. So I was the founding editor-in-chief that led about 100, 150 educators of SDFM to build these cases. And to now, they are subscribed by about 95% of the medical school across, and some of it internationally as well. So that gives me a lot of joy to build a new program. So I'm also in a Sophie Davis 6-year biomedical education program. I also now have heading off some 3-year accelerated program at Penn State. We started with family medicine, where you could finish medical school in 3 years and then conditionally accepted to the residency program. We now have 6 other pathway and some for MD, PhD, so kind of grow into a pretty big program. And I'm also overseeing the LIC. Currently, I serve as the assistant dean for pathway and innovation, and just doing things that have not been developed yet, and creating those pathways and different programs. Has been just really a lot of fun. So looking back, like, why do I choose family medicine? Some of it is that continuity, allowing me to see patient over time, become part of their life and contributing and helping them to kind of have the best health they could have. So that's really important. But the other thing is the diversity. I got to do so many different things, and there's so much flexibility. So I went from a comprehensive family physician doing OB to now I'm not doing OB. Then I was able to kind of venture into academic medicine. And I think that's the beauty about family medicine. You can't, if you discover some other experience and you want to specialize in something else, you could do it, because the training that you got as a family physician allowed you to pivot and take your career to a different direction or a different height. That I think a lot of specialty doesn't necessarily allow you to do. So that's kind of part of the reason why I ended up in family medicine, and just never had a moment of regret, and continue to find new joy in the discipline. So I think I would just stop it there, and maybe I'll share with you about what our medical school have done in response to COVID later. Was that okay? Okay.
Sure, that sounds great. Dr. Back, if we could hear from you now.
Hi there. So, Dr. Ling, we just started an advanced practice clinician residency, and we use Aquifer, so thank you. They're great. I am unlike you guys because I didn't train in New York City. I'm not affiliated with Sophie Davis. Dr. Gold was looking for a rural representative and reached out to me. I work up here in way northern New York, in the Adirondacks, and so that's why I'm on this call. I think my motivation for family medicine is very much like everyone else who's spoken. I think that the most important thing that I could say about family medicine is what Dr. Ling said, which is that unfortunately, students don't really understand that family medicine is the most diverse of all specialties and allows the most flexibility, with the exception of doing a sort of a surgical or medical subspecialty. And so I have colleagues who just want to see children, so that's what they do. I have colleagues who just do ER. I have colleagues who just do hospital. And then I have colleagues who do everything. And I'm one of those people who did everything, including emergency, including maternity. And most of my career has been in education as an associate program director. And then most recently as a program director. I had always hoped to do rural medicine. And this is sort of a late in my career move. And so I work in a rural health center on the border of Lake Champlain, right next to Vermont. And part of what I've been doing is a lot of opioid treatment as well. And that's relatively new for me, and something that I've become very passionate about and feel very strongly about, because I believe that this is, up until COVID, which will go away, the opioid epidemic has been the greatest epidemic that we've had since the AIDS epidemic, and one that really needs to be addressed by all of us. And so I train people in the use of buprenorphine, and we've been able to really spread treatment and save lives and sort of get people sort of some semblance of normalcy, because drugs really do hijack the brain. So anyway, so my career has changed, and so I do the opioids stuff. I do some medical education. We just started a residency program for nurse practitioners and PAs, because half of our workforce is nurse practitioners and PAs. And our experience in terms of the corona or the COVID epidemic is interesting, because we've been very fortunate. We've had very few cases up here, but we realize that we are really sitting ducks, because we don't have a robust healthcare system. We don't have ICU beds. We don't have a hospital. And we've been doing our best to try to prevent. So my organization, which is a combination of 18 federally qualified health centers, has set up screening and tents throughout the organization we don't, ironically, we're doctors, but we don't let sick people into our offices anymore. And we see the sick people in their cars. And we try as best to do an evaluation outside, which has been okay since the start in the spring. We're starting to move into like really cold weather. So I don't know, we've all kind of gotten some pretty warm clothes. They say there's really no bad weather, just bad clothes. And so we'll see how that all works out. And our goal is to really keep it at a level that, and we're working very, very closely with our county health department, where we can identify people and identify clusters and do contact tracing to prevent the spread. And so that's our expectation and our goal. So far, it's been working pretty well. We're very conservative area here. A lot of people, are sort of pretty conservative in their thinking, but fortunately, it has not been as publicized or politicized regarding wearing masks and whatnot as it has from what I can read in other parts of the country. So our patients are taking this seriously. And frankly, they're pretty used to being self-isolating because there's nothing to do up here. So, other than spreading it to the deer that they're hunting, I think that, people are being relatively careful. So that's kind of been our experience thus far. Thank you.
Thank you, Dr. Back. Dr. Okolo?
Hi guys, can you hear me? So nice to meet everyone. Yep, I'm Tony, and I won't have as much to say because I'm, by virtue of my recent graduation from Sophie, and I'm still a resident. But I graduated from Sophie Davis in 2015, and I did my last years at Albany Medical College, where I graduated 2018. So for me, family medicine, I kind of knew, I think, almost throughout Sophie Davis, I was going to do family medicine. I also was a president of the family medicine interest group when I was just a U2 at Sophie Davis. And it kind of just was the framework in which I understood medicine from a primary care, like comprehensive, like perspective and approach. I think when I got to Albany for a little bit in my third year, just like one of the previous panelists, OBGYN started getting really interesting to me because it looked like, oh, you can do medicine and you can do surgery, and that's really cool. And I like that. But I think what I realized quickly was like that continuity that I like experienced and really liked in family medicine I wasn't getting. So it made the decision easier to stick back and get back to my original roots, to go back to family medicine. And right now I am at Montefiore Family and Social Medicine. I'm doing my chief year. And it's really been great. I chose Monty, so it's an academic institution. And so we do have obviously other specialties, which also has its pros and cons. And you'll hear that like unopposed versus academic institutions. I think on one end, it's really nice to learn from other specialists that are in their field, like doing OB with OBGYNs, learning peds from pediatricians. At the same time, it is true that it does, especially in an urban setting, it could limit the scope of how you practice family medicine versus our colleagues in unopposed institutions, so maybe not as much procedure heavy. Even though I will say, in my program, we do a lot of paracentesis on the floor. We do a lot of lumbar punctures. We're usually second assist on C-sections. And then as far as procedure goes, we do a lot of like steroid knee, shoulder injections in clinic, as much as I can think of. As far as the coronavirus goes, so we have a unit in my program on Northwest 7, in the Moses campus at Monterey that is fully family medicine. And we became a COVID unit fully in March. So all the family med residents were managing, I think in total, about 50 beds in the entire hospital. Um, we had like our unit, which is a 36-bed unit, and then we had adjacent floors that we were also managing as well. And that we can talk more about that in depth, but I think it actually led to why I decided to do fellowship, because I really started appreciating end of life care. And so I applied for a combined geriatrics PAL care fellowship, and I just matched yesterday to Mount Sinai. So that's where I'm going for my next 2 years after this. And I think that's the beauty, like someone said, of family medicine is you can be full scope. And then if you decide that actually there's a niche that really speaks to you, you can really zone in and focus on that, which is what happened to me this year. So that's just the gist of what I have. Thanks.
Thank you so much for sharing, Dr. Okolo, and congrats. So now we're going to talk more about COVID, some specifics. I know, Dr. Leung, you have some slides prepared on curriculum changes in medical schools. I know medical schools have had to change how they do things. As medical students, we can all attest to that fact. So Dr. Leung, if you would like to share now.
Yeah, I just thought I am so proud of what some of the things that our students have done. And okay, did you let me share?
Yes, participants should have the ability to share the screen.
Okay, it said host disable participant screen sharing. So I guess you have to allow me to share the screen.
Okay, I think it should be working now.
Okay. Ah, yes. Yeah, so in March, you probably all knew, nationwide, everybody's, all the students were not allowed to be seeing patient face-to-face, so everything is stopped down. And our student was just so proud of them that they basically organized into this COVID elective where they are participating, helping to basically help out to take care of all kind of different needs that become a problem when COVID occurred. So we have a lot of students who kind of become helping out with contact tracing. We had on demand, we basically like a telehealth for screening, and they participate in that. There was a lot of outpatient follow-up where we saw patients, and then we want to know how the patients are doing because we can't see them in the clinic as much as we used to. So they participate in that. So there was just kind of a lot of different things that we're doing. They even become tutors for some of our faculty because school is also no longer taking place. So this is just kind of a long list of things, and I just kind of want to share with you what student can do. They also did a lot of research in the literature to see what recent things are published, so that they could create this resource list. So even physician who is practicing and taking care of COVID patient may not know what's been published, and so by the student doing that work really helped the physician as well. So just want to shout out to them of what they have done. And so then we also have to look at the curriculum. What do you do? What's allowed and what's not allowed? So we have to kind of check in with the LCME to see what is allowed. So basically what LCME, which is the organization that oversees medical education, have said that as long as we're meeting learning objective, that we could actually allow some of the modify our curriculum, and some of it might be a lot of virtual learning. Because if you remember in March, there's a group of students who are due to graduate in just a couple of months. So we have to like quickly come up with a curriculum to help them to meet the learning objectives so they can graduate on time. So that's kind of some of the things we did. So this is kind of, then we also develop a curriculum called Health System Equity Clerkship. So again, that kind of is virtual, but it get the student organized and learn about health system and how they react to COVID. And this is kind of some of the schedule that they have. A lot of it is really learning about health system, how do you handle pandemic. So we have a lot of interview actually from the CEO of the health system to the infectious disease person that kind of develop a strategy and how to take care of patients, to also talking to the laboratory people and how they're doing testing for COVID. And we have family medicine was leading quickly developing telemedicine. So we interview Matt Silvers and just to kind of talk to him about how they put together the telehealth, as well as the dean. So that has been a very good learning experience for our student as well. So the student have really got a chance to learn about how you go about responding to a pandemic. We also invited a lot of speakers from around the globe. So we have someone from the US, but also from Italy and from China. So that was really interesting. The other thing that we thought were a very important piece was that we very quickly separated healthy patient who came in to see their chronic disease management patient from patient who have respiratory symptoms. So kind of separating the sick from the well patients is very important because we don't want the well patient to get sick, but particularly also the patient who are immunocompromised. We really been kind of going through our schedule to see which of the patient might be immunocompromised and not have them come into clinic. And we instead change it to a telehealth visit. So we can still manage the patient, but not bringing them into clinic to avoid potentially contacting COVID. And then also all the students and residents are not allowed to see patients with COVID, and even patients who are being investigated for possible COVID, students are also not allowed to see those patients. So we also a number of schools from March to about June, a lot of schools really just basically stop students seeing patients, but we developed a different strategy. We basically developed something what we call the indirect patient care periods, where for about 10 weeks they were mostly seeing learning virtually. We use a lot of the ARCO4 cases. We use standardized patient via Zoom for them to practice seeing patients, and then kind of build up the clinical skills through Zoom. And then when they were allowed to see patient back again in June, they were prepared to do so. So I would say a lot of the learning was really through technology, from telehealth to virtual, to using an iPad, using Zoom to create something called like a virtual rounds, where a student will be connected by Zoom to the patient at the bedside, and they can interview them and then present back to the team, and also sit in the rounds and kind of learn how do you see patient, how do you care for patient in the hospital. Now, I think it's also important that students learn to take care of COVID patients. So while they are not able to see them in face-to-face, we could create virtual clinic where the student actually could see the patient using telemedicine. So I think I'll leave it at that, and I would leave the other part when we get to the discussion part.
Thank you so much for sharing that.
Sure.
I don't think many people expected to be learning so much about medical education today as well as family medicine. So that was definitely really interesting to hear. And I know that Dr. Rebecca Back has to leave soon, so I just want to let her talk a bit more about COVID and what that's like on a reservation.
Sure. So, uh, we're acutely, so I know that on, like, whenever I read the news right now, people keep talking about how there's not enough ICU beds, there's not enough hospital beds. So we are definitely dealing with that. And so I was working nights. So my schedule is all over the place. Sometimes I'm in clinic, sometimes urgent care, sometimes I'm on call for the whole hospital. And so on Friday, Saturday, Sunday, I was on night call. And so I figured I would just talk about my nights. At this point in the last, so we had no cases for months, which it sounds like is kind of pretty typical. And then slowly we started to get a rise. And so we are now kind of like in it again in the last 2 weeks. And so, for protection, I wear, so our policy at the hospital is that for any patient, I have to wear an N95 mask and goggles because we just assume that everyone has COVID, even if they're just coming in for a regular well child or prenatal appointment. And so as the night call doctor, I'm the only doctor in the whole hospital. I have a backup if I need to. I can call in my one other doctor, but for the most part, it's just me seeing patients. And what's kind of scary right now is that there really are not enough beds. So at most at my hospital, we have 10 beds for inpatient medicine, but we're having a nursing shortage because some of the nurses got sick with COVID, some from the hospital, but definitely the others were just choosing to travel even though they shouldn't. And so we had a nursing shortage there. And already, because we're an underserved area in rural New Mexico, we already don't have enough nurses. So on my nights, we only had 5 beds available. And everyone who's coming in basically had COVID. And most of them were doing fine. And we have a really good public health nursing contact tracing who can call them every day. And we send them home with pulse oximeters, which is great. And so our policy that we just made a few weeks ago is that we only admit people to our hospital if they just need oxygen and not high flow nasal cannula oxygen, which is like a kind of a higher need of oxygen. And anyone who needs high flow nasal cannula or is intubated, they have to go elsewhere because we are not an ICU. But there's no beds available in New Mexico. Normally we call this PALS line, which is great because, we can call them for literally anything and they'll give us advice because we are so rural and they know us really well, and they had no beds available. There were no beds available in Arizona either, and are actually the high flow nasal cannula machines that we were lucky to have bought. The place is 45 minutes down the road from us. They actually borrowed 4 of our 8 because they are desperate and they at least have ICUs. So now we're admitting people to the hospital who are on high flow nasal cannula, which is uncomfortable for us, but there was really nowhere else that we could bring them. I had one patient who was on just 1 liter of oxygen. And again, our policy is that we don't let those people go home. I sent them home on steroids because we couldn't find any beds for them anywhere. And then I think there was one person who was really, really sick in the hospital, and we had gotten them accepted to transfer. But again, the challenges with rural medicine is that there was a weather delay. And so there weren't enough planes. First, there was a weather delay, and then there wasn't enough planes to get to the hospital, and we were 4th on the list. So this person who went from needing just a little bit of oxygen went to needing high flow nasal cannula, and then we ultimately decided to intubate him, which is the highest risk thing. And the reason I mention that is for 2 reasons. The first is that I was wearing full PPE the whole thing, but I got COVID. So I know I look really, really good. I actually just have a mild cough, but that's, kind of one of the risks for, doing something like an intubation. And so I think I got it from there. And so I'm actually on quarantine for the full week. I and my family are doing pretty fine. The other scary thing besides that is that, so when we intubate someone, because we're so small and we don't, we know the initial, like how to manage someone when they first get intubated, and then what to do on the vent settings. But then we like get them out of here. We send them elsewhere because we are not an ICU. There were no beds anywhere at all. And so I left in the morning after the intubation, and my colleague took over. And for 8 hours, she called every single person that she knew, like every hospital, trying to get this person a bed. And we finally got him a bed. But I think what's scary is that, in the COVID pandemic, we are now learning that we have to, work outside of what we're used to. And so we're not, like, as a family doctor, this was never my plan. I know some family doctors are fine with vent management and ICU stuff. I never wanted to do that. And now we're actually training ourselves to do that, because I think that, as everyone's saying in the news too, I think it's going to get worse before it gets better. And we're really worried. We're already having a surge before these religious activities. And I think that it's just going to get a lot worse before. So that's kind of been my experience from the rural setting. We're definitely learning a lot, but there's a lot that's going on. And then, just the medical ethics is we're going to start having to figure out, the ideal situation, everyone gets admitted or transferred and all that, versus what are we going to have to do when there's just not enough beds available in any of the states around us.
Wow, that's an incredible story. And thank you so much for what you're doing.
Thank you, Dr. Back. Could you speak a little bit about how your patient population would feel about a vaccine?
Yeah, that's a great question. So we just got an email actually today about, so in the healthcare workers, because we're going to be the first people, they're going to be there's only 80 to 100 vaccines that we're going to be getting. So already they're trying to figure out how to prioritize, A, the people who do intubations, B, maybe the elder staff or people who have comorbidities, which is almost all of our staff have obesity or diabetes. I don't know why, but interestingly, my population in general, Zuni and Navajo, are really fine with vaccines in general, except for the flu vaccine. But all like other vaccines, I know other populations really are hesitant, but vaccines they know are good. I'm curious about the vaccine. The rare conversations I have, I think people are just terrified because we've seen so many people die. Again, I work with a high risk population where so many people have diabetes or kidney disease, and so we've had many elders die. So I think that people are going to be very eager to do the vaccine. And also, even though people hate the flu vaccine, so many people are doing the flu vaccine this year because they know how important it is.
Thank you so much for sharing, Dr. Back. I hope your situation improves.
Thank you.
If we could now hear from the other Dr. Back, a little bit more about what COVID is like up north.
Okay, so this is the other Dr. Back. It gives me great pleasure to listen to the other Dr. Back and hear all the stuff that she's doing, which is fabulous. Like I said, our experience is very, very different because we're not dealing with people with acute disease. And so we're dealing with people with chronic disease, trying to actually keep them healthy during this time when all the other resources are going elsewhere. So in the spring, we moved to telemedicine. And that's a real challenge out here in a rural area where a lot of people don't have broadband. And so that was a problem. We actually, one of our innovations was to make our parking lot a hotspot so that patients could actually connect with us from their cars by actually hooking into the broadband right in our parking lot, since we couldn't actually see them in the office. It was really a godsend, like I'd mentioned, for some of our Suboxone opioid patients, because as you probably have read, this has been a very, very difficult time for people with addiction. And And it was really important to us to maintain contact with folks. And it worked both ways. I found it actually very gratifying for me to be able to connect with my patients on a regular basis and have that sort of ongoing relationship. And then, as I had mentioned before, trying to deal with sickness, unfortunately, we treat everything as a possible COVID. So, because the symptoms are so broad. So I saw a patient yesterday in the office who had been seen in our COVID tent for nausea and vomiting, had a rapid test, which was negative, told that it wasn't COVID, ended up with persistent symptoms in the emergency room and had an acute cholecystitis and had her gallbladder taken out. So, still we have to deal with those basic chronic things that are happening all around us. We've got lots of patients. Our population up here is very elderly. We have a lot of patients who have multiple comorbidities, and they're terrified as well. They're very, very scared of actually avoiding coronavirus. And so part of the reason that we've been really kind of pushing the telemedicine is to be able to provide them with their care and reduce their exposure while maintaining some contact. So that's where we are now. We know it's going to be a long winter. Like Rebecca said, I'm getting more people who've never had flu shots to be able to start taking flu shots, which is good. I have some concerns about vaccines, but for the most part, most of our patients do adopt vaccines. We've got some folks who are vaccine, how do we call it, anti-vaxxers, vaccine atheists. But I think that we're going to get most people who are ready for vaccination. One of the things that I do as a family doctor is part of my sort of spiel with everybody is to sort of just talk a little bit about the virus, no matter what they're in for, to really reinforce the need to maintain their safety and to listen to public health messages. And part of it's also talking about the vaccine. And the impression I have is that people are really looking forward to it because it will allow them to sort of get their lives back in order. Thank you.
Okay, awesome. Thank you for sharing that, Dr. Back. Now, Dr. Ema, if you could share with us a little bit about how COVID is going with you.
So I do primarily outpatient medicine. So right now we don't have the capabilities to do acute COVID testing. So we're sending those patients out to be tested. So a lot of what I'm seeing is the patients kind of in the aftermath. And I think a lot of, goes into talking about COVID and how serious it is and hospitalization, but there's a lot of people who struggle to recover after they have the illness. So I've had patients who have had clotting issues like DVTs or PEs, patients who have like residual pulmonary issues or issues with like a fog or concentration, things like that. So it's helping those patients how to manage that. A lot of this is new to us, so we're just kind of learning as this goes along, what are the long-term effects. So a lot of what I'm doing right now is just kind of that aftermath. The other thing that I've been seeing a lot of during COVID is a lot of depression and anxiety. And this is, I live in Florida, so, I have a large elderly population, but also in college students and parents, because when schools shut down, the parents have been, homeschooling and also having to have a full-time job. And it's just a lot of stress that people are under. So I probably would say maybe 60% of my patients are struggling, and even patients who didn't never struggle with anxiety or depression before. And it's kind of hard in terms of navigating that, because normally you tell patients who are struggling, okay, what do you do for self-care? I hang out with my friends, or I go, go to the movies, or, go for a walk or something. And it's a lot of those things they're not able to do. So it's how do we navigate that and help them to deal with this? And then also normalizing it to the sense that most people think, well, I shouldn't feel bad. Things are not that bad for me. I don't have COVID, or nobody in my family does, but yet I'm still struggling. And it's to normalize it that we all have this shared experience, and that we all have our struggles. Life has changed exponentially for everybody. And so it's just educating patients. You're entitled to your feelings and going and struggles, because we all have this collective burden that we're sharing, and how do we navigate through that? And like I said, I'm a firm believer in the link between the body, mind, and soul. So a lot of patients I see, they'll come in and they're saying, oh, I have this backache or this stomach ache, and you kind of delve deeper, and they have some really big struggles, I think, which compound their physical health as well. So it's learning not just to address their physical needs, but also the mental needs and emotional and spiritual needs as well. So that's what I find that I've been doing a lot of during this time as an outpatient physician.
Yeah, no, I have also noticed a lot of my patients are having anxiety and mental health issues, and unfortunately, it's not just COVID, right? We have, all the social equity, social justice kind of things going on, and the elections and all kinds of stuff going on. So it's kind of one big problem after another, and it really takes a toll on your mental health. So sometimes what I tell patients is like, you got to manage your media intake. You may have to turn off the TV, leave your phone, put your phone down, and just really take a break, and not have these bad news kind of streaming into your well-being. So yeah, sometimes it's just, watch out for all those bad news coming in.
One of the things that I want to mention also is the effect that it's had on our colleagues. I'm pretty active with the New York State Academy of Family Practice, and certainly encourage students to get involved as well, especially through the interest group. And if you're interested, I can put you in touch with our student representatives from New York City, who are really reaching out to students. It's a great opportunity for students to get involved at an early level. But I'm fortunate because I work for a large FQHC. I get a salary, and Rebecca works for Indian Health Service, and she gets a salary. But we have colleagues who are in private practice, and they have really taken a huge financial hit, and are pretty much working for free just to keep their salary, to keep their staff paid, and hoping that this will eventually work out. So, and I've read in just some of our magazines that one of the biggest challenges we're going to have in primary care is a lot of physicians are leaving because they're going out of business, or they're getting towards the end of their career, and whereas they may not have been thinking of retiring until later, they're realizing that this is not sustainable at this point. And so that's going to be a huge hit going forward once we're beyond COVID, in terms of actually not having the same primary care force. And so we're really happy that you guys are future family doctors, and will be sort of able to take on that, because we're going to have a huge need to do that. And one of the things that I think is interesting about medical education is I've read some of the statements from the AAMC regarding the medical students and COVID, and the need to balance protecting medical students, but also recognizing that you are essential workers, because you are the essential future for physicians. And so, whereas you need to be protected, your health, it's also your education is essential for the future of this country. So I think that part's really important to remember as well.
And I think too that the other thing that I'm seeing, because I do have some patients who are actually physicians or healthcare workers, nurses, the toll that it's taking on physicians, not just financially, but I think emotionally as well too. We're kind of trained and taught, you just kind of push through, you have a job to do, you just kind of have to keep going. And we've been seeing a lot, and even in talking with online forums with other physicians, there's a lot of burnout that's going on, compassion fatigue, and it's how do we find ways, and then you're dealing with like grave issues, people having to ration out, resources, how do you do that and still be able to keep functioning and pushing forward? That affects anyone. I don't care who you are. Seeing people die and, doing everything that you can, it really takes a toll on you physically and mentally, and making sure that we're taking care of ourselves as well, because if we can't pour from an empty vessel. So I think that's another thing that I've learned. In the beginning, I was kind of, especially when people were not really taking it seriously down here, that was one of the things I struggle with, because I was like, I'm seeing how it's affecting my colleagues, and I wish I can impress on people more, and it was affecting my health. And I realized, okay, I need to kind of stop watching the news, like Dr. Young said. I have to engage in self-care and make sure I'm taking care of myself, eating right and exercising and all of those things, and talking. I think that's the other thing, is engaging with other physicians who are going through a similar experience. And, you know, this is the struggle. I just need to vent and to be able to go forward, because it does wear on you. And especially now, since we've been dealing with this for so long, it definitely takes a toll. So.
So thank you, Dr. Ima, and everyone for sharing a little bit there. Dr. Okolo, if you'd like to share a little bit about COVID and your experience with it.
Yeah, sure. So I was at Mount Sevier, and I guess this was right March, April, when New York was really hit really bad. So all of us, the residents in Mount Sevier, we didn't have a choice. We were definitely deployed. The entire hospital became a COVID hospital. So me personally, I started off in the ED, which was like obviously a hot zone. I think they actually were teaching us at some points how to intubate just in case. I remember it was me and a podiatry resident, and I'd never intubated, not even in med school, and they were trying to teach us like how to do it, which was really interesting. And I still don't know how to do it. I won't ever do it, hopefully ever again. But we saw a lot of COVID patients, obviously a lot of deaths, needless to say. I think personally, I signed 18 death certificates between March and April on my shifts personally. A lot of us were managing teams by ourselves, because that's just how much stretched our department was. There were nights, I think I was the only resident for about 12 COVID positive patients. We definitely had ventilated patients on our floor. We definitely had high flow. The way it was set up was like the ICU in our hospital was really accepting patients that they deemed to have the biggest potential to survive. So the sickest patients actually ended up on the floors, on our floors and on the internal medicine wards. And that was really hard for a lot of us who didn't expect to get that level of training and that exposure. So I guess so early too in our career, because I was like middle of my second year in residency, and we're like trying to read up on ventilation management. The crit care docs at our hospital were awesome. They would walk around just to check in on us, even at night, to be like, hey, how are your patients doing? Do you have any questions about the vent settings and all that stuff? And I had just been watching, when I got like little breaks between like rounding on the patients, I would just like go on YouTube and look up like how to adjust vents and peak flow and all things that I knew a little bit of, but I didn't realize to what depth I needed to know them. Obviously, ABGs, drawing blood gases, were becoming a very common thing for us. And that was inpatient. And on the outpatient world, obviously telemedicine became the full thing for us. We didn't actually start doing telemedicine until like, I want to say end of May, June. We were actually just not doing any outpatient medicine when the surge really hit New York City. And off the bat, you already start seeing how this pandemic really highlighted health inequities, especially in our Bronx community. Off the bat, you're telling people, oh, stay at home, to who though? Like my Bronx community, that all of them like are the breadwinners of their family and they can't stay home, many of which are undocumented and will not be eligible for any stimulus or government needed assistance, so they have to go to work. How do you social distance in one elevator in like a 19-story building with everyone who's trying to move in and out? How do you social distance when you take public transport to and fro to get to work? So it was just like all the messages that were being passed out while they were necessary were really not applicable to a lot of our patients. And needless to say, like a lot of them the Bronx was definitely the hardest hit at that time. Even telemedicine, while it was great, like a lot of our patients don't speak English as a primary language, and a lot of the interfaces aren't really conducive to other languages. And then, needless to say, also the financial burden of like buying a laptop just to do video calls, or like some patients who never really had phones, and like how we had to figure that out with grants and stuff. So I think it was just really like on that end too, just obviously we're dealing with a biological pandemic, but there was also a lot of social determinants that were just really highlighted and just showed like just how deep our health inequities run in our community. And I think that was also a little bit hard for a lot of us to process as well. I think for me, and I I mentioned this a little bit earlier as to why I decided to go into geriatrics and childcare. I really realized like it was really tough on patients because obviously we had to ban visitation rights in our hospital. So a lot of patients were not only suffering with a terrible disease, but doing so alone. A lot of them who don't really know how to navigate our healthcare system. And I really realized the importance of like preparing people for like a very terminal disease or a very like tragic event. And it really was there was a big difference between like the patients who were prepared for this and the patients who had never had this conversation and their loved ones were not prepared to say goodbye. And I think I really, really valued the importance of like goals of care conversations and end of life. That's what we had to do a lot often. And just something to not learning to not do when it's too kind of too late, but like start to do like just like even in your regular clinic, if a patient's coming to you and like, hey, what are your advanced directives and all that. So it's something I really, really grew to appreciate and decided to make a whole career out of going forward. So I think that's basically the sum up of like my experience.
Thank you for sharing that. Your experience is definitely different from everyone else here because you're a resident. So I honestly can't even imagine. Like I know some of our Sophies who have recently graduated and their first year residents trying to learn how to intubate patients and having to deal with such a heavy patient load just out of medical school. So even hearing from you, like I can't even imagine what kind of conversations you must have had that you never imagined that you would have. So thank you for sharing that. And I know Dr. Liang, you had a few more slides to share and also a bit more about your COVID experience as well that we'd love to hear.
Yeah, God, you guys are sharing these incredible stories, and I just really want to express my appreciation of all that you're doing. I think collectively, I think we're doing really well now in the healthcare area. The other thing that I have heard from nurses who works in nursing home too, is the other struggle of, for a long time the family's not allowed to go in to visit their loved ones, and it's hard enough for us who are cognitively together, but think about those who have cognitive challenge, and try to explain to them that you got to stay in your room when they can't comprehend what's going on, and they're really missing their family because their family usually are there to see them often. And I had a patient who literally just lost tons of weight, and she began staying in her room, staying in bed, and just really declined. And I was just trying to figure out like what else can I do for her. And the nurse told me like, so she has seen so many of these cases, and she calls them, the broken heart syndrome, because they're so depressed, they're so sad, and they can't quite comprehend why their families are not here to see them. And the family is also struggling with too. So there's just so many sorrow and so many suffering from this pandemic.
Well, thank you to all the panelists for sharing your experiences. I know you guys have been through so much, so thank you for that. But we do have some questions. So Barbara's going to read them off if you guys wouldn't mind answering them for us.
Yeah, so the first question that we have, it's kind of a two-part question. So as step 2 CS moves toward a virtual platform, our clinical education might follow and become more centered around telemedicine. How prevalent do you think telemedicine will become as a result of this pandemic? And how important do you think this skill is to learn as medical students? As well as, will telemedicine ever take over in family medicine? That's open to anybody who wants to answer.
I'd like to go for that. So I speak partly because this is new to me. I had never done telemedicine before. I spent my entire career teaching residents. And so the mainstay of our education has been sort of in the health centers and face-to-face. I think that telemedicine is one of the, one of the lemonades with this lemon. one of the real positive developments, because we've sort of done away with all of the regulations that have been hampering it. And we really went from 0 to 100 in a very, very short time. I think it's here to stay. I don't think it will I don't think, but it's still early. I don't think it will overtake, because it is important for us to actually sit with our patients. I mean, there is something with that relationship, but it really does open up the opportunities to maintain contact when otherwise it's not so easy. Whether you're in New York City and it's hard to get from one place to another because of transportation, or because of family responsibilities, or because you're sick, or whether you're in my neck of the woods and you've got a snowstorm. And I think that we're still learning how best to actually utilize this technique, and so this is all new to us. So you students are sort of in the same place we are in terms of how to do it. The advantage is that it's also it gives us an opportunity to have like a virtual home visit, because I'm looking at their home. I can kind of get a sense, and I will often ask them to show me around as long as we're there. And so it allows me a way to look at them and look at patients in a way that I never have before. It gives them a little bit more of power. It can be, it's sometimes too much power. Like, I had this patient who I met on his porch, and he's smoking a cigarette. I said, I don't really care if you're on your porch. You're still in the doctor's office. You can't be smoking a cigarette, And so he he adhered to what I told him. But so I mean, it works both ways. So I think it's a really good question, and I think that we will be developing better and better ways to actually make this work for both our patients and ourselves.
Yeah, I would agree with Dr. Beck. I think telemedicine is here to stay, but it's never going to replace medicine. I mean, there's something just so special about looking at the patient in your eye, looking at them in the eyes, and touching of the hand or the shoulder, that personal connection really come when you're there face to face. There's nothing more powerful than that. It just won't happen, through Zoom. Like, I'm looking at all of you now, but I don't feel the same connection as if I were in the room with you. So that huge, meaningful therapeutic relationship really came from that relationship and came from that personal touch. So I don't see it ever going to replace telemedicine, will ever going to replace in-person a doctor's visit. But I do see a lot of benefit of it, though. So like today, I saw a patient, we dealt with a lot of medical issues, and I changed a couple of the medications. And I'm going to see her back in 3 months by telemedicine. So she doesn't have to drive in long distance to come see me, wait for me till I, become available. She could just kind of connect through the Zoom or through the platform. And also, I don't know about Dr. Beck, but I'm always late. So if I'm waiting, they have to wait for me for 45 minutes. It's probably very annoying to wait for in my office. But if it was in her home, she could probably be doing her whatever she had to do, and then when it's time for me to see her, then it wouldn't feel like she lost so much time. And the other thing is the transportation. I think there are a lot of patients who really do have transportation. They can't come because no one to take them, or the car wasn't working. But if it's telemedicine, then that can be done a lot easier. And I heard from my colleague too, a lot of psychiatrists have gone virtual, and that made it much better because, the stigma of going to see a psychiatrist is sometimes a little uncomfortable, but hey, who's checking on your Zoom call, right? So it may take it a little easier to meet with your psychiatrist or your therapist. So I think it has a lot of benefits. And we're in the journey of trying to figure out how best to kind of fold the telemedicine as a tool into that patient-doctor relationship.
Yeah, just to add, I agree with everything the previous panelist said. I do think it's fair to say I don't think it'll overtake in-person visits. I do think there is still a lot of room for improvement with telemedicine. We talked about like obviously like being language friendly to people who English is still not their first language and how to make interpreter services seamless. I don't really know any of the platforms that have figured that out yet. Also confidentiality, especially with patients who don't live in big homes, and like being able to discuss personal visits where they would have been able to have the privacy of the doctor's office. Now they're in their home with other people who may or may not know some of their medical conditions. We still have to figure out how to tackle that. So I think there's still a lot of things we need to think of. I think it's going to be part of a larger effort to really get people out of tertiary care. So it's, you know, like obviously the biggest issue we have right now is making sure like we have enough beds available in our tertiary institutions for people who actually need it. So we're seeing obviously telemedicine is one way to do it. We're talking about other initiatives like the hospital at home initiative for people who have conditions like maybe like mild pneumonias or UTIs that were initially only managed in a hospital, and now we're looking for how to provide that hospital level care in their homes. So I think what we're seeing is now an intentional approach to how do we provide certain level things that were initially only provided in a tertiary institution. How can we bring that to the patient's home and outside of the hospital so that we can really make those beds available going forward? It's just something like this ever happened.
Yeah, so Dr. Okolo, is that how you say it? So as you were describing about how you have to manage the ICU and all those sort of things, make me also think about tele ICU. You know, so if there is a physician, critical care medicine doctor who can actually be consulting multiple hospitals or multiple units by kind of assisting people who are less comfortable with intensive care to just give them, you know, little pointers or consultation on the go. That could really also help with particularly rural community, you know, hospitals, right? Post-COVID, you know, where they need those subspecialists that they couldn't get, but maybe through telemedicine, we could get this expertise into those communities in need.
That's a really great point. Prior to moving up here, I worked in Kingston, New York, at a hospital that became part of the Westchester Medical Center complex of hospitals. And they had a project where they had a critical care unit that maintained tele services for they had some 8 affiliated hospitals, and they were able to actually look in on the rooms and the monitors of all of the patients and all the critical care units. It was staffed by 2 critical care doctors 24/7, looking over what was going on. And they came and did grand rounds, and they presented their data, and their outcomes were so much better because they had this ability to oversee what was going on. We were in the process of actually doing that for our neonatal resuscitation, because we were all family doctors who were responsible for doing all the neonatal resuscitations. We were not neonatologists, and we had just developed a way to have the neonatologists join our resuscitations by camera during the actual resuscitation to be able to overlook what's going on. So it's a great way to actually bring some of the expertise of other specialties into more remote communities. It's also a way to have greater access for everybody. So these are things that bring us all closer together, which is a fabulous idea.
Yeah, so you probably also heard about something called Project Echo,
Sure.
which is similar concept where through Zoom and connection, you know, we could bring in expert to kind of, you know, people can present cases and get consultation, you know, through Zoom, which would just kind of make some of these expertise more accessible.
So these are certainly the advantages of our of the internet. I mean, Rebecca, my daughter, had talked about how she was a little girl when she was on the Navajo reservation. I was a doctor, and we had none of that. I mean, I don't want to talk about how I used to walk to work through the snow, uphill, both ways. But you know, things have changed a lot through the opening up of the world to access, and so people can get access to information, access to specialists through telephone, through telemedicine, and it really has the potential to help to equalize some of the disparities that we see among the different types of healthcare systems. If we can figure out a way to actually provide for that throughout the country, I think that would be a great thing.
All right. And the next question we have, the governor of New York has asked hospitals to reach out to retired doctors and nurses to help address physician shortages. Have you seen similar campaigns in your states? And how does this make you feel?
Well, here in Florida, we haven't gotten to that point, thank God. But when things started to kind of escalate, when we were kind of hitting our surge, the licensing board did kind of just send out a heads up, if we need you, we're going to pull you kind of email. And I think from my own personal belief, and I think the consensus from my colleagues is the same, you know, it's just, these are unprecedented times. Wherever we're needed, we're going to just do what we have to do. You know, we kind of have to brush up on a couple of things and probably would use UpToDate and Google a lot. But I think we're all willing and ready to help if or should that time come. But as of right now, thankfully, we haven't gotten to that point.
Yeah, in Pennsylvania, I live in Hershey, and our cases are definitely picking up, but we're not at that point where we felt like we need to call an emergency call to our retirees yet. Hopefully we'll get there. Hopefully the vaccine gets here first.
Yeah,
I think that most doctors want to meet in that this is what we do. I commend the effort. I worry about it because most people are retired because they're older, and so you're subjecting older people to a risk. And I don't know if you ever read Medscape, but they've been publishing a list of all of the healthcare people who have died as a result of this, and I know that it spans all ages, but certainly the older ones are really the older doctors and nurses who've died have been really tragic consequences of this pandemic.
Yeah, I was gonna say in March and April in New York, I remember there were messages like that, especially with nursing and physicians. And I think I'm not sure to what extent the folks who are retired or just not in commission at the time were called to serve. Like I think some just took on more of a telehealth role so that those who were balancing telehealth and inpatient could then focus primarily on their inpatient work. And I don't recall it lasting or being to the degree where they did a full call of everyone who was retired or anything like that. So I think as far as my thoughts, I think people can work in the capacity that they feel most comfortable in. So if maybe telehealth is extremely important, especially in a pandemic, if people can take up that role, that's absolutely fine. And maybe relieve some of the other people who can then come to the floors, et cetera.
Yeah, we institute something similar to that. So we have what we call an acute respiratory clinic. So anyone who's screened with any potential symptom of COVID, such as fever, chills, cough, sore throat, whatnot, are not allowed to come into the clinic during regular business hours. But we do have this respiratory clinic. We don't want to call it COVID clinic because people won't come. So anybody with any kind of respiratory symptoms will come to this evening clinic, which is 5 to 7. And then when we see these patients, we're fully geared up with the regular PPE, so that we could take care of these patients, and it's basically everybody's rotate through that. But those who had respiratory, like they have asthma or kind of comorbidity or certain age group that put them more at risk for COVID, then those providers are more likely to volunteer or rotate through more of telehealth because we still need the service, but we also want to keep them safe as well. So that have actually worked out pretty well. And kind of back to what Dr. Beck was saying too, is about they just certain profile of practitioners are more likely to just have a higher morbidity and mortality for COVID. And so definitely anybody who's over 70 have these huge, just a significant and higher risk factor. But also primary care physician, because when we're seeing patient, we don't have the same PPE that an anesthesiologist would have. Like they would have, they're so used to scrubbing into the OR, so they have the N95. They really know how to don the appropriate PPE and how to take it off and so forth. That then they know how best to kind of not get themselves, infected. Whereas I think in primary care physician, we're not used to kind of get that sterile technique. We haven't done it in a while. And we also don't have the same equipment. So we have surgical masks. We don't have N95 masks. So, and we never know who's going to come in that has COVID, right? So sometimes we actually could potentially be at a higher risk.
Regarding New York State, last spring, they did start working on this, and they put a call out for volunteers. I know that I volunteered. My wife was a nurse, volunteered, and they did follow it up. So we all got phone calls. They went through a checklist of what it is that we knew, what it is that we were willing to do. And so I believe that I'm in a database somewhere to be called up if need be. And it was really gratifying how quickly they were actually able to do that. A lot of times calls go out and you send a response into the void and never hear anything back, but there was follow-up. And one of the real pleasures, and I say this to the medical students, of being a doctor is that this is a sacred profession. And no matter what we end up doing, I think that we all still maintain a certain allegiance to the oath that we take and took. And I don't think you see that in other people, in other types of professions. I know I'm a little biased, but I think that's pretty wonderful, so that you young people, you're part of the same thing that we older folks are part of, in terms of our need to really help people in times of need.
And I think our last question for our panel tonight, have you had any experience dealing with any chronic COVID cases?
I think so. I've noticed in clinic, some people have this residual shortness of breath that sometimes can't be explained by anything workup we've done, other than, and all we know is they did have COVID back whenever. I've also, so we're learning that obviously some patients are at increased risk of forming clots after COVID. And to the point where I know there have been a lot of studies, and we're looking at the Marina trial is really influencing a lot of hospitals in terms of how they decide who gets prescribed anticoagulation after discharge and for how long. So those are the two things I know I've been personally dealing with, and not sure really what the approach is. I know Monty's policies, anyone with a chronic illness, and especially someone who had COVID, as a prophylactic measure, we send them home with apixaban for at least a month, and then have them follow up and see how they're doing. That's the most I can think of right now as far as long-term sequela. But it's usually some prolonged respiratory, just milder presentation.
Yeah, that's what I've been seeing a lot in my clinic. Mainly the shortness of breath, the residual cough, fatigue. That's the big one that a lot of people have been struggling with, is just fatigue, and they just feel like they're moving through quicksand. And then the clotting. I've been seeing a lot of clots with the DVTs and the PEs. So those are the main things that we've been dealing with. And then a lot of patients too, I think it's just especially if they've had a prolonged course. Like I have several patients who've been in the hospital for 3 weeks, may have been on a ventilator for a week or longer. It's just the deconditioning. So it's a lot of like physical therapy, occupational therapy to get them up and moving around to their normal state. So that's another thing that I've been seeing a lot of.
That was the final question for the night. So I'd like to close out this panel by saying thank you to Margaret, because without her, none of this would have been possible. She was the one that reached out to all of you wonderful panelists and allowed you to speak with us tonight. So thank you very much, Margaret. Also, a big shout out to our panelists. You guys shared so much today. And I hope everyone here and the folks that had to leave early learned a lot. It was very informative. And I hope those people who are considering family medicine maybe like it just a tad bit more now. I know I certainly do. And so ends our night. Thank you so much.
Thank you. And I appreciate all the wonderful things that everybody's doing in this pandemic. So thank you very much.
Likewise, good luck to you all, to all the students, and thank you for the opportunity to participate. And I'll plug once again for the New York State Academy of Family Practice.
Thank you guys for the opportunity. And Margaret has my information. So if anybody, anytime, if you have any questions or concerns or anything, please feel free to reach out. I'm more than willing, you know, even just as a mentor or anything, just to talk. That's fine.
And I agree with that too. So feel free to reach out. And if you have any questions or curiosity, you know, happy to talk and chat.
I'm here. Thank you guys so much. Really appreciate it.